Hi everyone, my name's Kate Wood, and we're going to be talking about high frequency oscillatory ventilation, also known as HFOV. The learning objectives for today are going to be to define HFOV, recognize the differences between this mode and other modes of ventilation, understand what the indications and advantages are, identify risks and contraindications, know how to apply initial settings and adjustments based on the clinical presentation and data available, and understand and apply weaning strategies. This mode of ventilation is a mode where you take very, very small tidal volumes that are usually less than anatomical dead space delivered at very high frequencies. It maintains a mean airway pressure while you're avoiding large pressure changes that are associated with conventional ventilation, and this is generally considered a lung protective mode. You'll see it most often used in infants and neonates with conditions like BPD, meconium aspiration syndrome, extreme prematurity, or diaphragmatic hernias. These are not the only uses for it, though. All right, so let's talk about how this actually works. So, how it works is a constant pressure is applied to the lungs, and that pressure is maintained by your difference from the top to the bottom pressure. So, that would be your amplitude. So, you can see here, this would be your mean airway pressure, this line right here. And the amplitude is from here to here. So, the difference in these two pressures is what gives you that mean airway pressure. And this is why amplitude is also known as delta P. Um, and this is where you have your mean airway pressure, and then these curves right here represent the tidal volume that's being delivered. So the tidal volume is determined by your amplitude and your frequency or your hertz. So if you have very high hertz, your curve is going to be smaller, so you're going to have less volume being moved with each breath. Or if your hertz are lower, you're going to have larger curves that are going to move more volume with each breath. So it's kind of the opposite of conventional ventilation when you think about it, where with conventional ventilation, if you have a higher rate, you have a higher minute ventilation. Whereas with HFOV, generally, if you have a lower rate, you're going to have a higher minute ventilation. So while we're talking about all the different controls, the way that we manage oxygenation on the oscillator is through your mean airway pressure, MPOT, and your FiO2. You manage your ventilation using your power, which determines the amplitude, and your hertz, which determines your rate. A backdoor way to help with oxygenation is also using your hertz in the same way that lengthening your eye time would work in conventional ventilation. If you decrease your hertz and you give yourself a longer inspiratory window, that can also help with oxygenation. Your eye time is generally set at 33%, and it's rarely changed. In the 9 years I've been practicing, I've never changed the eye time on an oscillator. And when you're looking at which of the two oscillators to use, you have the 3100A and the 3100B. The 3100A is generally for your neonatal and infant population, very small children under 35 kilos, and the B is for bigger kids and adults or anyone over 35 kilos. So going back to talking about the 3100A versus the 3100B, these are made by Vyaire, and this is the most common ventilator used to provide HFOV, especially in the United States. But in the UK and other European countries, the Draeger Baby Log, the VN500, can also provide high frequency ventilation. I also do transport, and on our transport isolate, we have the TXP2D ventilator, which is essentially a transport oscillator, but instead of using a piston, it uses a sliding venturi with a flow interrupter. All right, now differences between HFOV and other modes of ventilation. So in conventional ventilation, you're using very natural tidal volumes with essentially a natural rate, trying to mimic natural respiration. When you're using an oscillator, however, you're not giving that 4 to 6 cc's per k, or sorry, 4 to 8 cc's per kilo of ideal body weight. And you were using with HFOV, you're using active inspiration and expiration, whereas in conventional ventilation, it's generally a passive exhalation. So on the oscillator, your piston is firing at rates of 180 to 900 breaths per minute with those teeny tiny tidal volumes, and it's a push-pull motion, push-pull, push-pull. It's not a breath and then let off, breath and then let off. This allows to have that constant mean airway pressure, and it's a little different than high-frequency jet ventilation in that it's its own separate machine. It doesn't use a conventional ventilator. With this mode, your lungs stay expanded, which increases alveolar recruitment without the use of high peak pressures, and this helps reduce volutrauma and barotrauma. All right, indications for the oscillator. So the oscillator can be used anywhere from micropreemies all the way to adults, but you're more commonly going to see it, especially in those NICU and PICU settings. Some of the main things that we use the oscillator for are extreme prematurity. So we're talking about your 22, 23 weekers, your 500 grams or less babies, on your bigger term infants with severe meconium aspiration, pulmonary hypoplasia. So if they didn't have enough fluid, their lungs didn't develop, or they had some other, like a congenital diaphragmatic hernia that caused pulmonary hypoplasia. When you have recurrent air leaks, so if you've got a baby that's got a recurrent pneumothorax, or a baby that has had a TEF-EA repair, or is in the middle of undergoing surgeries for a TEF-EA repair, and they have those consistent air leaks, or if they have PIE, like your teeny tiny babies and their lungs look like popcorn, it's a good time to use the oscillator. Again, congenital diaphragmatic hernias, especially ones that are severe and they're waiting to go on ECMO before they can get repaired. If you fail conventional ventilation, so this is when we're getting more into like the bigger kids and adults where you've done what you can do on the conventional ventilator and their peak pressures are just too high, your oxygen requirement is still really high, everything that you're doing with conventional ventilation is not working, so you can try to use the oscillator. If you have conditions that cause reduced compliance or chest wall rigidity that cause difficulty ventilating, so your neck perf babies where their bellies are huge and they are rock hard and they're distended and it's squishing up on their lungs, so you're having a hard time expanding. If you've got a kid that is, or an adult that has severe edema, like diffuse edema, and it's causing that chest wall to have a hard time moving, things like that can really benefit from the use of the oscillator. Right, diving in a little bit more to some of the advantages. So you are looking at minimizing atelectasis. So all of those alveoli that you're having a hard time getting open, you can pop open, but you're also reducing alveolar overdistension. You're reducing volutrauma. You can have improved gas exchange, reduces air leaks, and it can also decrease inflammatory markers found in the lungs. I've got this quick video here that I guess you'll have to pull up outside of this video, but it's just basically a 10-second video showing what the lungs look like when you initiate the oscillator. It goes from being, atelectatic, not a lot of movement, to that slowly building them up, getting that good recruitment, and then the wiggle of the lungs. Another important thing to note is that when you're initiating the oscillator, you want to connect and then hit your button that creates that mean airway pressure, and then start your oscillations. That allows for the best recruitment. And then you have to be careful when you're disconnecting the oscillator, because any disconnects The second that you disconnect, you are going to end up with collapse. So all of that pressure that you've worked so hard, all of that recruitment, you disconnect, you're going to lose a lot of it. All right, risks and contraindications. So there aren't any true solid absolute contraindications for using the oscillator, but there are several conditions that you need to take into consideration and weigh the risks versus benefits. Uh, so if you have a patient that they are hemodynamically and they have hemodynamic instability, their blood pressure is really low, they're on pressors, they're having issues with their heart rate, any of those things, you have to be careful because when you initiate the oscillator, since you're maintaining that mean airway pressure consistently and you're not having the normal um, distension and reduction of the lungs, it can cause drops in your blood pressure. If you have obstructive lung disease, if you have certain cardiac conditions, traumatic brain injuries is a big one because, again, you're increasing that intrathoracic pressure. And when you increase that intrathoracic pressure, you can also increase the intracranial pressure. And then with the oscillator, not necessarily in the preemie population or your NICU population, but in bigger kids and adults, since you are not breathing in a way that would feel natural, they may need increased sedation. So if you have a patient that you don't want sedated, you need them to be moving around, you need them to be mobile, then the oscillator may not be the best choice, since mobility is limited with the oscillator due to the circuit, the risks of disconnection, and how it works. In the NICU I work in, we do still do kangaroo care and holding with our intubated oscillating babies as long as they're stable. And it just takes a little bit more work from the clinical team to be able to do that, but we found that there is still a benefit to holding these babies if we can reduce the amount of disconnections that happen from the oscillator. Alright, initiating the oscillator. So you've got some general rules of thumb. Different physicians, different hospitals may have slightly differentiating practices, but this gives you a good idea of where to start. So when you're looking at your bias flow, which is the constant flow being fed through the circuit, on a neonate, you're going to look anywhere from 15 to 25 liters per minute. 1-year-old to 8 years old, 15 to 30. Over 8 years, up to adults, 25 to 40 liters. A general starting point is usually 20 liters, and then you use the bias flow as well as your adjustment knobs for your mean airway pressure to get to the mean airway pressure that you want. So if you have higher mean airway pressure needs, you're going to need more flow. If you have lower mean airway pressure needs, you're going to need less flow. When you're looking at starting on the mean airway pressure, where do you start? So if they are already on conventional ventilation with a neonate, you're going to look at 2 to 5 centimeters of water pressure above their mean airway pressure on conventional ventilation. And for an infant and up to an adult, you're going to look at probably 5 to 8 centimeters of water pressure above where their mean airway pressure is on conventional. Now, if you have a micropreemie that's going straight onto the oscillator because that's how your NICU practices, um, general rule of thumb that I have seen is usually like 10 to 12 cms of water pressure is where you would start. When you're looking at setting your amplitude, again, no set rule of thumb. It's going to depend on why you're going on the oscillator. So if you are going on because you have a baby with neck and their belly is hard and big and distended, you're probably going to need higher amps. Whereas if you're going on because they're a micropreemie and that's how you practice, they might need less. So basically, you're just going to turn it on and you're going to adjust until you get a perceptible wiggle from their nipple line down to their umbilicus, also known as the chest wiggle. And then setting your frequency or your hertz. Again, this is going to depend on the disease process, why you're going on the oscillator, and physician preference, but in general, a preterm neonate, 15 hertz or 900 breaths per minute. Term neonate, you're going to start around 12. Infants, young children, around 10, and adolescents up to adults, anywhere from 6 to 8. I've had neonates on the Hertz of 3, which is generally the very lowest setting, and that's generally a very, very sick baby that we're having a really hard time ventilating. Monitoring during use of the oscillator. So chest x-rays are your best friend. So once you initiate the oscillator, it is really important to get a chest x-ray within an hour of initiation to assess your lung expansion, making sure you're in that 8 to 10 rib expansion range. You're not overexpanded, you're not underexpanded. You also obviously want to monitor your blood pressure and your heart rate. You have that increase in intrathoracic pressure. You may drop their blood pressure. They may need some uh, blood pressure support like dopamine or epi, uh, or you may need to back off on that mean airway pressure just depending on what's going on with the baby. You can't use an end tidal. So conventional ventilation, we throw that end tidal in line and we get that beautiful capnography waveform. Can't really do that with the oscillator. So in general, you would use a transcutaneous CO2 monitor alongside regular blood gases to assess ventilation. Uh, and then obviously, as with any kind of ventilatory support, we're going to monitor your SpO2. All right, so let's look at a case example. You have a term infant that weighs 3 kilos. With severe meconium aspiration, they failed conventional ventilation. So you're not oxygenating, you're not ventilating, they're on 100% FiO2. Your mean airway pressure on the conventional ventilator is around 18. You throw them on the oscillator with initial settings of mean airway pressure of 20. Your power setting is 2.5, which is showing an amps of 34, and you've got fair chest wiggle. It's not perfect, but it's there. Your hertz are 12, your I time is 33%, and a bias flow of 20 liters. You get an hour, ABG 1 hour post initiation. Your pH is 715, CO2 is 75, uh, and your bicarb 24. The patient's still requiring 100% FiO2, and the chest x-ray only shows 7 ribs expansion. So what kind of changes could we make? There's a lot of different options here. Your mean airway pressure is already kind of high, but you do have somewhere to go. You could increase your mean airway pressure if their blood pressure will tolerate it. You could increase the power. Obviously, your CO2 is pretty high. You need to blow off more CO2, you need to increase that pH, and they may oxygenate better if their pH is better. So you could increase the power. Drop your hertz. They're still needing, more ventilatory support. And then remember, your hertz can be your backdoor to help oxygenation as well. Drop your hertz. See if you can oxygenate a little bit better. And then last but not least, consider nitric oxide and surfactant therapy. So you've got a bad meconium aspiration. What are the other things we use? Nitric oxide and surfactant. All right, let's talk weaning. Patients can be weaned down to essentially very minimal support, essentially CPAP, and extubated from the oscillator. However, I've been doing this for 9 years. Only a handful of times have I seen providers actually follow through and wean down and extubate straight from the oscillator. Generally, they're going to wean down to bare minimum oscillator settings and switch over to conventional. So unlike conventional, when you're weaning, you're going to increase your frequency or increase your hertz, not decrease your rate like you would in conventional. And then you're going to monitor your blood gases, your TCOM, your SATs, your lung expansion, and just patient tolerance during weaning. Can they tolerate less sedation? Is the disease process that got us on the oscillator in the first place, has that resolved? Is their belly better? Are their lungs better? Is their x-ray better? Things like that. Can we manage secretions? What's your mean airway pressure? Are you still needing a high mean airway pressure? Is your mean airway pressure in the 20s? Or are you down in the teens? These are all things to think about while you're weaning. Quick recap. So, HFOV is a ventilatory mode that uses teeny tiny tidal volumes at a really high rate to enhance gas exchange while minimizing lung injury. You're reducing that barotrauma, you're reducing that volutrauma, overall protecting the lungs. Generally used in neonates and pediatrics, but it can also be used in adults. Indications: air leaks, diaphragmatic hernias, pulmonary hypoplasia, failing conventional ventilation, and any type of disease process that decreases lung compliance. There's no absolute contraindications, but you have to think risk versus benefit with every single patient and take it at that case by case basis. Are there risks of putting them on the oscillator outweighing the benefits? Are we going to tank their blood pressure? Are they going to need too much sedation? Do we need them to be mobile to reduce swelling? Things of that nature. And then, unlike conventional ventilation, increasing the rate is considered waning. That's a really important thing to remember. This is all my references. I'll have it posted with the actual PowerPoint slides so that if you wanted to look at these, you can find them.